Hello everyone, my name is Felipe Hades. I'm a medical oncologist and I'm here alongside with Gil Morgan and Carmine De Angelis hosting the first ESMO discussion, an international discussion about breast cancer. So to start, I'm going to call Gil and Carmine to explain how this works will go. Hello guys, you're on.
Hello everyone, this is Gil Morgan. I'm coming live from Sweden.
Hi everyone, this is Carmine from Italy.
So we're going to start our case discussions. First, we are going to have 4 presenters coming from different parts of the globe. We have 1 expert panel member. Originally, we were supposed to have 2, but unfortunately, Dr. Kurigano could not make it due to circumstances beyond his control. But we have Dr. Theo Fukakis, who is an associate professor of oncology and a senior consultant at Karolinska Institute in Stockholm, Sweden. He's a very active researcher, and he will be part of the expert panel.
Okay guys, so
Theo?
here we have 4 cases to discuss, and I'd like to introduce you Theodoros Foukakis. Please, Theodoros, screen please. Hello Theodoros, you're live.
Hello everyone, happy to be here with you today. I'd like to thank the organizers for inviting me to be a member of this panel. So my name is Theo Foukakis. I'm a breast oncologist and an associate professor at the Karolinska Institute in Stockholm, Sweden. I'll be happy to discuss these cases with you.
Okay, so without further delays, I would like to introduce just a brief explanation of how it works. We have 4 cases. Actually, we opened a call for cases. We had lots of cases, I think 12 cases, and we selected 4 that we thought that were most emblematic of each specific breast cancer subtype or subspecialty. The first case then will be presented by Dr. Georges El Haken from the St. George Hospital University Medical Center in Beirut, Lebanon. So please, can you have Dr. Georges? Hello Georges, you're live. Can you introduce yourself, please?
Hello, thank you for giving me the opportunity to present my case today. I'm George El Hashem, Assistant Professor of Clinical Medicine at the University of Balaman, and currently engaged at the Department of Hematology and Medical Oncology at St. George Hospital University Medical Center in Beirut, Lebanon. I'm going to discuss today a case about the management of oligometastatic triple-negative breast cancer, a case I followed and was treating when I was in Brussels at Institut Jules Bourdin and the Hôpital Erasme. Years old female patient who was diagnosed at the age of 57 in August 2015 with a left breast right up centimeters. The biopsy revealed an invasive ductal carcinoma with metaplastic differentiation, grade 3, triple negative, with the KI. Workup consisted of a chest, abdomen, pelvis CT scan as well as a bone scan, which were negative. She was operated with axillary lymph node dissection with a final pathologic stage of triple negative and follow that unfortunately stopped after the 9th week because of a grade 3 drug-induced bruises.
Guys, sorry, we have some problems with the connection of Dr. El Hakshin. Then, if you don't mind, I will present a couple of slides while I will try to get Dr. Hashin back. So can you put his slides with me, please? So guys, what Dr. Hashin was telling you is that is a patient, 60 years old female patient, that has a CT1 and 0 and was a triple negative metaplastic differentiation grade 3 with Ki-67 of 30%. She had no metastasis in the beginning, and then she was submitted to a tumorectomy and left axillary lymph node dissection with the same clinical pathological features. Had no metastasis out of 16 lymph nodes. After she received adjuvant chemotherapy with EC 4 cycles, followed by weekly paclitaxel, but she stopped the paclitaxel because of induced bolus toxidermia. She received adjuvant radiotherapy, and she had no BRCA1 or 2 mutations. In March 2018, she had a mammogram and a breast ultrasound that showed a right breast outer quadrant hypoechoic suspicious lesion of 11 versus 8 millimeters in size with right axillary lymphadenectomy. Sorry. So she was a CT1 plus positive with a contralateral breast. The biopsy of the mass and the finding of aspiration of the right axilla showed invasive ductal carcinoma with metaplastic differentiation grade 3, ER, PR negative, and HER2 negative, Ki-67, 70%, which was similar to the first disease, despite of a higher Ki-67. She had chest, abdomen, pelvis CT scan with 2 lung nodules of 1.6 and 1.4 centimeters in the right lower lobe, and a bone PET CT with no metastasis. The PET scans show hypermetabolic mass associated with a hypermetabolic right axillary lymphadenopathy and 2 hypermetabolic nodule in the right lower lobe of the lung, confirming probably metastasis. But actually, would you recommend a CT-guided lung biopsy knowing that the patient was a 40 packs smoker? So we're going to give the answer here and leave this to Theodoros to discuss. The patient was submitted to a biopsy and was compatible with triple negative breast cancer. Afterwards, what would be your first line of chemotherapy in this case, knowing that it's an oligometastatic triple negative breast cancer patient with BRCA1 and 2 non-mutated, not mutated, with an excellent performance status and completely asymptomatic. So it was impossible to challenge with taxanes because of the allergic reaction. She was oligometastatic with PS0, but tumor shrinkage is required in order to control the primary lesion and maybe trying to resect the metastatic lesions. So platinum base would be a possibility in that case, knowing that there are no BRCA1 or 2 mutations. So this is another question for Theodoros. And in that specific case, she received carboplatin and gemcitabine, 1 gram per meter square in that specific schedule. In the baseline exams, you see the breast lesion, the right axillary lymph nodes, and the metastasis in the lung as well. After 2 cycles of chemotherapy, she had a stable disease in the breast, stable disease in the axillary lymph nodes, and shrinkage of the nodules on the lungs. After 4 cycles, she had a response in the breast, stable in size, but with an SUV that decreased. Partial response in the axillary nodes, and it had a good response in the lung. So she got a response, but the better response was at the lung. So the questions are for the panel, for Theodoros. After achieving this objective response and disease control, would you proceed with a radical procedure with mastectomy axillary lymph nodes followed by adjuvant radiation and maybe stereotactic radiation of the lung nodules? Or in other words, would you try to cure a metastatic or oligometastatic disease? And in case of surgery, would you proceed post-surgery? Would your decision be influenced by the pathological response on the specimen? And there's an indication for BRCA1 somatic mutation in that specific case. Any role for PARP inhibitors in non-mutated BRCA1/2 patients? So I'm just giving the feedback what happened to this patient of Dr. Georgi. She had a mastectomy with axillary lymph node dissections. The pathologic results are still pending, and they're planning to give her radiotherapy to the lungs as well. So let's move to Theodoros now to see what he thinks about the case.
Yes. So this is a case of oligometastatic disease in triple negative breast cancer. What I would like to note to start with is that in this case we don't really know if this is a new primary tumor or if it is a relapse of the tumor that was operated 3 years before the relapse. So to start with the first question, I think that if it is possible to feasible to take a biopsy, it's good to do it. That's like a general comment. Sometimes, in this case, of course, the possibility of another diagnosis is very low. So if we have a biopsy, a diagnosis from the breast, and the lung lesions are not accessible, then you just proceed with therapy, I would say. Then coming to the second question about the treatment. Of course, re-challenge with taxanes is not is impossible. So I think that the two alternatives here would be either to re-challenge with cyclin-based therapy or carboplatinum as a. I would also, in this case, I would also choose the same therapy, carboplatin and gemcitabine. And so the third question, let me just. Yeah. So then we come to the main part of this case, whether you should treat micrometastatic disease radically with local treatment of metastasis. In general, I would say that in such a case of triple negative breast cancer, I would be a bit reluctant. And this is what we actually see quite often in practice, that when you try to treat locally, then that plays the systemic therapy both before and after. And I would say like that in 90% of the cases you would experience a negative outcome because of the local treatment, especially if this treatment is surgery. But of course, there are some patients that would respond. So I would discuss with the patient, and it's important that the patient is informed that there is a risk that he has a worse clinical status because of surgical treatment, and that can delay the systemic therapy.
Okay.
Theo, I just got a comment from Georges that commented on Facebook, and he said his last question is concerning the role about BRCA somatic mutation testing, and if there is an analogy with CREATE-X.
Well, yeah, I think we have a biopsy from the tumor, so I think it's good to do it. We don't have so much data yet about the somatic mutation of BRCA and whether we should treat it in a different way, but there are ongoing studies, so I think it's important information. Theoretically, you would expect that the tumors with somatic mutation would respond in the same way that tumors with germline mutations do.
He means it for maintenance with Xeloda.
Yeah, can I make a comment on this?
Go ahead.
Yes.
Yes, I mean, the CREATE-X trial actually was a trial that tests the maintenance with capecitabine in patients who received neoadjuvant therapy and didn't get a pathological complete response. So, and then this trial showed that the maintenance, I mean, the treatment with capecitabine was associated with better results in terms of progression-free survival and also in overall survival after 5 years of treatment. The subgroup analysis of this trial showed that the higher benefit was in the triple-negative subgroup. And in this case, I mean, I don't know if it tends for the addition, I mean, the treatment with capecitabine, since we are not in the case of adjuvant treatment, but we are more in the setting of metastatic disease. Of course, we have an indication for the activity of capecitabine in this in patients with negative breast cancer, but I'm not sure that we can translate this result in a metastatic disease.
Yeah, I completely agree with this. I don't think that the results of the CREATE-X should influence the treatment in this case.
I'd like to make an additional comment.
I actually have a couple of questions that came from Facebook, and one of them is coming from Paolo Tarantino, and he wonders, was the axillary lymph node dissection indicated in this case, or could she have received a sentinel lymph node biopsy instead?
Theodoros.
Yeah, I think also that we don't need to treat the axilla radically in this case.
Okay. And one more question from Facebook from Keen Mu. Is there any role of eribulin?
Theodoros, please.
Yes, I would probably use eribulin as the next line of treatment. In this case, and I would prefer it compared to capecitabine, for example, since it's a triple negative case.
Can I make an additional question? When you see this a patient metastatic like this, most probably, I mean, we're not going to cure this patient, right? But it's preferable that you leave this patient with the least disease that we can, because maybe we can have a longer period without chemotherapy, which is favorable for quality of life and maybe avoid toxicities in the beginning of the treatment. On the other hand, to achieve this, in that specific case, we use a combination of two drugs, which is not the mostly used combination when you talk about, combination is not the mostly used regimen when you talk about metastatic patient. We try to use single dose. So how would you decide to use two drugs in a case like this versus one drug? How do you see the situation?
Well, it depends. Generally, using combination drugs is indicated when we are interested in the objective response. So I think that once the treatment plan involves also radiation therapy of the lung nodules or surgical excision, then it's worth taking the risks involved with combination therapy.
Okay. Gio, Carmine, is there any additional questions coming from Facebook, Twitter, anywhere?
There is. Is there any evidence to evaluate androgen receptor expression, in this case, aiming AR-targeted therapies?
Theodoros, please.
Yes. Well, there is quite limited data on that, but in my institute, we try to evaluate as many possible targets as possible. So that includes AR, PDL1, BRCA in the tumor, and so on. So limited evidence,
Yes.
but at some point you will probably need to use therapies that are not approved. So it's good to have some kind of.
There is one question, one more question. I
knowledge.
think the last one, right?
Okay, let's do it.
So it's from Dario, and he said that both. I lost the question.
It says, as a resected oligometastatic disease, a maintenance can be scheduled. Both gemcitabine monotherapy or capecitabine are valid options in de-escalation, preserving subsequent lines where a relapse is still possible. Any preference for metronomic maintenance?
Yeah, we don't have any data on this. I would suggest that once the patient is macroscopically tumor-free, that both options are valid. Either give a metronomic type of just like capecitabine, or wait and see. We don't really know. It's there's no evidence.
Good, good. In my institution, most of these patients that we just follow, we will not do any kind of chemotherapy. We don't have, as you said, evidence to say that even metronomic or full dose chemotherapy would give these patients a disease-free interval longer than treating them when they have a relapse. Okay, very good. George, sorry to drop you. Sometimes live broadcasts to have these problems, but be sure that we will count on you for the next times. And without further delay, let's go to the second case, which is a case from Paolo Tarantino from Istituto Europeo di Oncologia in Milan, Italy. Paolo, are you there? Hi, Paolo.
Hello, hello everyone. Can you hear me?
Yes, perfect. I'll put your slides.
Thank you very much.
Slides, please. Okay, go ahead.
So, okay, I'm glad to be here today with you to discuss my case about a neoadjuvant treatment of an early breast cancer with a BRCA mutation. And I'd like to thank Gilles, Felipe, and Carmine for giving me this opportunity, and Dr. Foukakis for joining us. I'm currently following my medical oncology residency at the European Institute of Oncology in Milan. And every day we see a lot of women with breast cancer, especially triple-negative breast cancer, which I think it's a big unmet need of oncology right now, because we only have chemotherapy, and maybe in the future we're going to have immunotherapy following the results of the Impassion 130. But maybe we could also rediscover some old drugs for this disease. The patient I'm going to talk about today is a female with 39-year-old with a good performance status, no comorbidities, no concomitant medication, and our only family history is one aunt with 47 years old with breast cancer. And in February 2016, she noticed a rapidly growing breast lump in the left breast, and after 2 months, she consulted a breast surgeon. And at the clinical examination, he found another breast node on the other breast. So if we can move on, we can see that the first diagnostic step was a breast ultrasound, which showed 2 nodules. Next again, please. Okay. 2 nodules, 2 hypoechogenous nodules with irregular margins, 2 per 1 centimeter on the right and 3 per 2 on the left. And both nodules were biopsied, and the histopathological result was on both sides invasive breast carcinoma, grade 3, estrogen receptor and progesterone receptor negative, HER2 negative, and therefore both of them were triple negative breast cancer. At this point, the question is it a metastatic presentation of a breast cancer, or is it two bilateral primaries? And to figure out that, we performed a PET-CT scan, a staging scan, and it showed no distant metastasis, but only the two nodules, and there was also no axillary involvement. So the blood tests that we performed were unremarkable, and it's time for the first question. In this setting, would you propose to this patient an adjuvant or neoadjuvant chemotherapy? So would you administer a chemotherapy before the surgery or after the surgery? And here are some possible answers. Neoadjuvant to ensure a breast conserving surgery, or maybe neoadjuvant because, move on please. Next. Next please.
Sorry.
Okay, neoadjuvant to gain time for the genetic testing, or adjuvant because of better results in overall survival or local recurrence rates. And in our case, we perform a neoadjuvant treatment, and this gave us time for the genetic testing, and we discovered that the patient was BRCA1 mutated, which helped us with the subsequent choices in the therapy. Question 2 is, which chemotherapy regimen would you have chosen, either neoadjuvant or adjuvant? You could have chosen either an anthracycline taxane-based regimen, or a dose-dense regimen with growth factors, or maybe a platinum-containing regimen with anthracycline, taxanes, and platinum, or also PARP inhibitors, but in a clinical study context, since they're not approved in this setting, or maybe an anthracycline-free regimen. And in our case, as you maybe have seen from the title, we went for a platinum-containing neoadjuvant treatment with doxorubicin cyclophosphamide followed by carboplatin paclitaxel. And the patient also received an LHRH analog for fertility preservation. And the third and last question is, which surgical treatment would you have chosen? And you could have been either conservative with a lumpectomy on both sides and sentinel lymph node biopsy, or maybe more radical with a mastectomy and axillary lymph node dissection. And in our case, since we knew that the patient was BRCA mutated, we went for a bilateral mastectomy. And since there was no clinical or radiological involvement of the axillas, we only went for the sentinel lymph node biopsy, which was negative. So we can move on. And okay, so let's go back to the neoadjuvant. So we have the diagnosis, and we perform an MRI of both breasts as a baseline exam, and then we put some clips on both nodules, and then we started the LHRH analog. Next, please. In May 2016, we started the LHRH analog, and in June, we started the chemotherapy with doxorubicin cyclophosphamide every 3 weeks at the standard doses for 4 cycles. And after these 4 cycles, we performed a breast ultrasound to understand what was going on. And actually, on the left, there was a partial response, while on the right, there was a tiny shrinkage, but it was still a stable disease. And toxicities were the ones expected. So then the second part of the treatment was carboplatin, LC6 every 3 weeks for 4 cycles, and weekly paclitaxel at standard doses. And after this, we perform another breast MRI. Next, please. And the breast MRI showed complete response at the right breast and some residual disease of nearly 2 centimeters in the left breast. So at this point, we performed the bilateral mastectomy. And as you can see in the right breast, there was a pathological complete response, and there was only some fibrous tumor bed with inflammatory cell remaining. While in the left breast, we still had some carcinoma, 1.7 centimeters, so we had a partial response, and of course, it was still triple negative. So let's resume the case a bit. we performed the neoadjuvant treatment, and we had a radiological complete response on the right and partial response on the left. Then we performed the mastectomy. Next, please. And there was some residual disease on the left. And on the basis of the creative study, which we talked about before, we decided to perform also some adjuvant capecitabine for 8 cycles. And after that, we discussed with the patient the option of a preventive salpingo oophorectomy, and she decided to perform it. So she received also a laparoscopic salpingo oophorectomy, and there was no neoplasia. And I'm glad to say that right now the patient is still in follow-up and still negative for recurrences. Thank you.
Okay, thank you very much. So Theodoros, could you give your impression about this case, please?
Yes. So I think that the first question regarding the primary treatment, I totally agree with treatment that the patient received. We would also proceed with neoadjuvant chemotherapy. I think that's a standard choice for all patients with triple negative BRCA mutated. Now the next question is the role of adding carboplatin, and well, I don't think that there is enough evidence to say that all patients should receive carboplatin in the neoadjuvant regimen. However, there are some indications from the literature, and there is the latest paper that is out from Professor Leubel and colleagues. It is a new analysis of the JEPAR-6 trial that they also show that there is some indication of overall survival gain by adding carboplatin. This is not significant, but as I told you, the data are quite limited, and it could be a matter of power. It's a very interesting study. It came out in Annals of Oncology a few days ago.
Okay.
But I think that it is a good choice first to give dose dense AC and then to add carboplatin to paclitaxel.
Okay, sorry to interrupt you. Gio, Carmine, is there any questions flying from Facebook anywhere?
Yeah, no, I would just to point out that this is a patient of 39 years old. So, and then with triple negative breast cancer, and there is, of course, the need to test for the BRCA mutation. And I guess that this patient, there are 2 points. The first one is that this is a patient that needs to be evaluated in the context of a genetic counseling. So, and this especially for the choice of the treatment, that of course then it will be a mastectomy, mastectomy, and then for the fertility preservation. So I think that I agree with the inclusion of the platinum in the regimen of the neoadjuvant regimen. But I want to stress the concept that for this patient, the best treatment involved a genetic counseling and the fertility counseling for the to choose the best over than the chemotherapy, the systemic therapy, and the surgery, but for other aspect of her life, to improve her quality of life. So I agree with the choice for this case, specific case.
Okay. Joe, any remarks?
Yes, and then
yes,
regarding the surgery,
we actually have a comment from Georges. He states neoadjuvant chemotherapy may be to test the chemosensitivity of the tumor on top of gaining some time to get the genetic testing. The pathologic response is a prognostic marker. Could we choose a platinum-based neoadjuvant chemotherapy irrespectively of VRCA testing results as per results of the meta-analysis published a few months ago in Annals of Oncology?
Good questions. Theodoros, what are your thoughts about it?
Yes. So actually, what the current literature say is that BRCA mutation does not seem to be predictive for carboplatinum. It's rather that it's prognostic. It gives a higher chance of achieving pathological complete response. And then the data, even from the meta-analysis, they only speak for a higher PCR rate, but we don't have enough data to know if it increases the disease-free survival over overall survival. But in the absence of data, I agree that we could, at least in select cases, as in such a patient, I would include carboplatin.
Okay.
And then regarding the surgery, there was
setting, right? The TNT trial shows a benefit of platin overdose taxol in BRCA mutated patients, and alongside with this meta-analysis and the data from GEPAR 6. I think we have, it's not definitive information, definitive data, but have data from a bit from everywhere pointing to that direction that platin has a role in BRCA mutated patients.
Yeah, that's correct. However, the results of the TNT in the metastatic situation have not been able to be replicated in the neoadjuvant situation. Not exactly, but as I thought, it could be a power issue. But no studies in the neoadjuvant, either the GEPAR 6 or the brightness that have been analyzed. They haven't shown a predictive value of BRCA mutation for carboplatin use.
Okay, any further questions? Gio, Carmine?
Yes, there's one more question that was coming from Dario Trapani. It states, any role to incorporate 5-FU in neoadjuvant regimen for triple-negative breast cancer, like example FEC? As per GIM sub-analysis, which use FEC and EC or FINCS? Would you prefer still EC-AC or FAC-FEC?
Theodoros.
Yeah, I would prefer the EC or AC. I think it's the GIM subgroup analysis that it was predefined, and there are more data showing that the addition of a F5FU or an analog does not give much in this setting. On the other hand, we have the data from the adjuvant treatment with the CREATEX, and there I would definitely recommend capecitabine adjuvant as these patients receive.
Okay, thank you very much.
Thank you, Theo. Well, we have another question from Franklin Pimentel from Brazil, where he states, in ESMO this year, some section discussed about adjuvant capecitabine according to CREATEX indications. I was told that the study has not evaluated patients post-platinum-containing neoadjuvant regimens. Do you agree with this concern? Which dose was used in this case? How do you handle with radiotherapy, reducing dose, delaying capecitabine, or radiotherapy beginning?
Yeah, it's true that we don't have data on that, but I don't think that we have any indications that the results of CREATEX would not apply to patients treated with carboplatin. Then the question about radiotherapy, I think it's not answered from the literature. In general, I would say that we prefer to give capecitabine first and then proceed with radiotherapy.
Okay, thank you. We had this doubt as well when the study first appeared, and then I remember having emailed the investigators And we didn't get any answer, of course, because most probably everyone was firing these emails. But by the study, you see that 70% of the patients, they had received radiotherapy. So in the study, most of the patients, they did radiotherapy first, which does not makes much sense in my head, because the problem is disease, metastatic disease, and not local disease. So I agree with you. I would do capecitabine first and then radiotherapy after. Any further questions, or can we move to the next case?
There is one question. If you can wait. Carmen, do you want to take this one?
Yes, the one from Fahimi, right?
Yes.
So he said there is one caveat in this nice presentation: being young female treated with LH-RH agonist to preserve fertility. Would you recommend salpingo or oophorectomy?
Good question. Okay, Theodoros.
Yes. Well, as it was mentioned before, I think in this case it would be good if the patient was evaluated by a hereditary tumor board. And what we would also ask here was if there is any family history of ovarian cancer, and in that case, what age.
Yes.
So, of course, if there are young relatives with ovarian cancer, then it would be good to proceed with salpingo-oophorectomy directly.
Okay,
but if there are no cases of ovarian cancer and the patient does not have any children, wants to have children, maybe you could consider doing as it was done in this case, trying to protect the ovaries and do some fertility preservation and do the salpingo-oophorectomy later.
Good. Okay, guys, thank you. I mean, this is a very interesting case, lots of things to discuss. I think we selected these cases that are difficult to end up having lots of things to discuss. So, guys, let's move forward. The next case is from Dr. Atul Batra, that unfortunately cannot be with us here. And then Dr. Santosh will present in his behalf. Dr. Santosh is from the All India Institute of Medical Science in New Delhi, India. Thank you for being here with us. Can you introduce yourself?
Yeah, I'm Dr. Santosh from All India Institute of Medical Sciences. It's 9:30 p.m. in India, so good evening to everyone. Maybe good morning from little other places.
Okay, thank you.
So can I go ahead with the case?
Of course.
So next slide. So our case is a 49-year-old premenopausal lady. Presentation with left breast lump. Clinical examination showed T2N1 stage. So in view of good performance status and salvageable by breast conservation, she underwent breast conservation surgery and ALND after biopsy, which was estrogen and progesterone receptor positive, but HER2 was negative. FISH was also done, which was negative. The histopathology showed T2N1 with 2 out of 12 lymph nodes positive, without any lymphovascular or perineural invasion. There was no extra nodal extension. So next slide. Following this, she received standard of care chemotherapy, anthracycline 4 cycles, followed by 4 cycles of docetaxel, followed by whole breast radiation. And in view of hormone receptor positive, she was and premenopausal status, she was started on tamoxifen. This is way back in 2010 before soft and text. And later, she was kept on regular follow-up with annual mammogram and bone density measurement. So after 4 years, she presented with new onset severe pain in right hypochondrium. Evaluation at this point showed new hypoechoic lesion, which on PET scan further showed further progressive lesion on bony lesions in the thoracolumbar vertebra and iliac bone. Biopsy was done from liver lesion. It confirms metastatic carcinoma, but interestingly, the HER2, which was negative previously, now turns out to be positive on immunohistochemistry. So further, we went ahead with Fitch and we confirmed it. It was positive, dual probe ratio of 4.5. So we have recurrence after 4 years with change in molecular status. In view of HER2 positivity now, she was given weekly paclitaxel along with trastuzumab for 12 years. She had very good response in view that after 3 months PET-CT scan done showed complete metabolic response. Later, she was kept on trastuzumab maintenance and evaluation at this point of time, her FSH and estradiol were in the postmenopausal level. Hormonal therapy was changed from tamoxifen to anastrozole. And in view of skeletal metastasis, she was given zoledronic acid monthly for 12 cycles, then 3 months. Later, on follow-up, next slide. So she remained asymptomatic for next 3 years until April 2017. Then she presented new onset back pain. So PET scan done at this point of time, new L5 skeletal lesion. There was only single skeletal lesion, so she was given single fraction radiotherapy and the treatment of maintenance trastuzumab, anastrozole and zoledronic acid were continued. 1 year later, she progressed again with 2 kg unintentional weight loss. Evaluation showed new liver and bony metastasis. At this time, we have repeated the biopsy. Although there was concordance in estrogen and progesterone receptors, again the HER2 receptor are negative at this point of time on third progression. Sorry. So can we go ahead to the next slide? So at this point of time, being HER2 negative, we changed to CDK4/6 inhibitor and fulvestrant. She is doing fine. So the questions are in this case and special circumstances are baseline at presentation, her HER2 was negative. At first progression, she had HER2 positivity. There was a change of histology from HER2 negative to HER2 positive. Later on third progression, the positivity of HER2 was changed to negativity. So how frequently do you encounter these? What do we have the data? So if we have bone only progression, is there any data for switching zoledronic to denosumab? So always biopsy is needed in multiple time progressing patient in a metastatic breast cancer. These are the questions and interesting points in our case we would like to present and what do the expert panel suggest in our case. Thank you.
So, Santosh, thank you very much. Now I think you gave a hard time to Theodorus to discuss this case. Theodorus, what do you think?
Yes. Yeah, it's actually a very interesting case, and this is something that we see in practice, not so seldom. So yeah, this is a classical case of a heterogeneous tumor, and this is actually what happens when you try to target the HER2 positive clones. Then you have progressive disease in the hormone receptor positive clones eventually, and vice versa. So I totally agree with the concept of a rebiopsy in this patient in case of progressive disease. And then I think that in many cases, in practice, we would try to combine the endocrine treatment with HER2 targeting treatment.
So
then,
my question now is, we had
of course, knowing that there might be some over-treatment there.
Okay.
And then the next question about denosumab, we don't routinely do that. Don't have any indication that we could by switch from zoledronic acid to denosumab that would delay the progressive disease in the bone.
Okay.
And then there was another discussion point. Let me
I think
just
it
see.
was pretty much this. What drove my attention to this case is the very long periods of disease control. See, in the first place, you have 4 years, and then after when they did trastuzumab, you had like 3 years of disease control, and then now with cyclin inhibitors, which are amazing drugs, We don't know what's going to happen, and the doubt that comes to my mind is, should we stay with the trastuzumab plus fulvestrant plus a cyclin 4/6 inhibitor? We have the data to do this. Should we believe that they are still heterogeneous disease, or this time is full luminal disease? What are your thoughts about this?
I mean, I will keep. I mean, there is no data about combination of fulvestrant plus CDK4/6 inhibitor and plus anti-HER2 therapy so far. There are some trials that are testing this hypothesis, but in this specific case, I will keep the anti-HER2 therapy, of course, and then maybe add just the fulvestrant, since I mean it will be an optimal therapy for the ER positive disease, and since also this and not really aggressive disease, since we are taking this patient for a long time.
Gio, what are your thoughts about it?
I have a question.
Okay, go ahead.
My question is, the patient has a progressive disease. So in this scenario of plus minus positivity and negativity of HER2, do we need to change the anti-HER2 from trastuzumab to pertuzumab, yeah, TDM in this scenario? What is your take on this?
Good. Theodoros, what do you think?
Yes, I think if we don't have any data of progression of the HER2 positive disease, I don't think that it's necessary to switch treatment. Of course, we could discuss whether the first line treatment would consist of a dual blockade with both trastuzumab and pertuzumab. But I mean, in this case, the patient was treated with trastuzumab only, and it seemed to work fine against the HER2 positive clones of the disease.
But would you be comfortable of taking out trastuzumab, or you keep trastuzumab and do like Carmine said, just change the hormonal therapy and keep trastuzumab without CDK4 inhibitors?
I would continue with trastuzumab.
Okay. Guys, any questions from the internet?
And there's actually quite a bit of questions from the internet. So if you don't mind, we'll take over now. So my first question here is coming from Evgenia Kashenko from St. Petersburg, who asked Dr. Santosh, did you ask for a second pathologist opinion?
We have reviewed the pathology in our pathology board. So every time the results I have displayed with you are concordant. So initially there was negative, at progression it was positive, and again at second progression it was negative. So two methodologies were done for HER2, and they were concordant with two pathologists also.
Okay. And Evgenia has the same question for Dr. Fakakis. Do we normally ask for a second opinion in these kind of situations? Theo?
Well, it depends who your pathologist is, I would say. But in general, I would say that the FISH or in situ hybridization assays for HER2, they should be quite concordant between pathologists.
Okay. We have a question coming from Manoy Kumar. He wonders, what is the rationality of switching to denosumab?
The rationale was because the patient has bony progression. So we thought that changing to denosumab might be helpful. We have not yet changed. So it was a postulated question. Yeah, interesting question whether changing would help.
I think you have a point there, because you don't have this answer, and there is disease progression with the use of course, you don't use zoledronic acid to avoid bone progression, but maybe there is rationale to try something different. But I don't think we have this answer. But I would consider as well, changing everything, just because to change. I don't have any biological rationale to explain this, but maybe. I don't think it's a question that deserves investigation, at least, in my opinion, of course.
Yeah. I have another interesting question. Is from Dario. Do you generally stop zoledronic acid or denosumab after a scheduled period, particularly in a setting of oligometastatic bone involvement, or proceed indefinitely lifelong?
Good questions. Let's put this Theodoros in the fire now.
Yeah. Yeah, this is a very interesting question and a very hard one. We don't have evidence, but biologically speaking, I would suggest that after a couple of years of treatment, it should be safe to stop treatment. Well, with a biological rationale. But then I know that in practice, in most of the cases, clinicians just continue with treatment, so as long as it is not toxic.
Okay. Any further questions, or move to the next case?
Yes, Paolo Tarantino had a question for Dr. Santosh. He wonders, was it pertuzumab available in the country as first-line treatment, or was it avoided?
We have availability of pertuzumab in current scenario. We don't have it maybe 2-3 years before. So we have recent availability of pertuzumab and even TD1 available. So it was not available few years back.
Perfect.
Okay.
Okay. Any further questions, or should we move to the next case? Very difficult case, huh? This one. I don't think we got an agreement here again.
But we have lack of information and data on denosumab actually, and very interesting and difficult case.
Okay, so maybe you can follow the case in the comments after, when you have an idea in the oncology, ESMO Young Oncologists. I think it would be nice for us to know what happened. Okay, guys, so let's move to the next case. Thank you very much, Santosh, for your presentation.
Thank you very much.
The next case is from Maria Alice here from Brazil. She could not be here, but we taped her, and then we have her Skyping, telling what happened with her patients. So this is a difficult case at the same time because of the medical parts of it, and also about the public health systems issues that we have here in Brazil. So we're moving with her case now. Check. Let me put the case.
Hi everyone, my name is Maria Alice. I'm a third-year oncology resident from Porto Alegre, Brazil, and I'm going to present a case of heart failure disease after a HER2 dual blockage and the importance of a multidisciplinary approach in this case. So this is a 32-year-old female patient. She was premenopausal, non-smoker, and she had no previous medical condition and no familiar history of cancer. She had a performance status of ECOG 0. So what happened is that this patient was initially diagnosed with an invasive ductal carcinoma of the right breast, clinical stage 1, clinical node negative in 2011, when she was 25 years old. She was submitted to a breast conservative surgery and a sentinel lymph node dissection, and the pathological report was PT1 and PN0. She had a tumor of 18 millimeters and a grade 3. The immunohistochemistry panel revealed a tumor with estrogen receptors positive 80%, progesterone receptors positive 20%, and HER2 positive. The KI67 was 40%. She was referred to genetic evaluation because she was really young, but she had no BRCA or TP53 mutations. So this patient received adjuvant chemotherapy with doxorubicin and cyclophosphamide for 4 cycles and 12 weeks of weekly paclitaxel. What happened is that by this time the adjuvant trastuzumab wasn't approved and available by the Brazilian public health system, and she didn't receive adjuvant trastuzumab. She completed the adjuvant radiotherapy of the right breast and started adjuvant endocrine therapy with tamoxifen in 2012. So in summary, she had an invasive ductal carcinoma, stage 1, hormonal receptors positive and HER2 positive that didn't receive adjuvant trastuzumab. 4 years later, in September 2016, during the adjuvant treatment with tamoxifen, the patient presented recurrence of the disease with pulmonary, bone, and hepatic metastases. So you can see here in the images of the CT scan of the lung and the bone metastases. In October 2016, so we started first-line palliative treatment with docetaxel every 3 weeks and zoledronic acid. We also asked for the Brazilian health system to provide dual HER2 blockade with trastuzumab and pertuzumab. And after 6 cycles of docetaxel, she presented stable disease, and the use of trastuzumab and pertuzumab was approved after 8 cycles of docetaxel. So she was submitted to docetaxel plus trastuzumab and pertuzumab for 4 cycles. And after that, the patient presented stable disease and she was asymptomatic, and we discussed the case with our multidisciplinary team, and we opted to suspend chemotherapy. And the patient continued receiving HER2 dual blockade associated with zoledronic acid and anastrozole after ovarian suppression. Her CT scans revealed a very good response with complete response of the hepatic lesions and a significant reduction of the pulmonary nodules. She had no more bone pain or any complaints. So what happened with this patient is that she presented a cardiotoxicity from the treatment. After 6 cycles of trastuzumab and pertuzumab, she presented a significant decrease of the ejection fraction. So here you can see in the graphic, before we started the treatment, she had 55% of ejection fraction. And after 6 cycles, the ejection fraction decreased for 31%. Okay, and she was referred to our oncology team, cardio-oncology team. By this time, we stopped the trastuzumab and pertuzumab, and we repeated the echocardiogram in 4 weeks. And by now, she was asymptomatic, and the cardiologist started medication for heart failure disease, and we repeated the echocardiogram in 4 weeks, and she continued to present a decrease of the ejection fraction, and she started to have symptoms of heart failure disease, with dyspnea, edema, and hypertension. So hospitalization was needed to use IV medication, and then she became progressively better with recovery of the ejection fraction after 6 months of the initial cardiotoxicity. So she, in April 2018, she had again 57% of ejection fraction, and she was really questioning about the treatment, and she wanted to be on anti-HER2 blockage. And by this time we discussed the case with in our tumor board, because she was a really young patient with metastatic disease, and she had a great response of HER2 treatment. And we talked to the patient about the risks. We talked to our cardiology team, and we decided to re-expose the patient to HER2 blockade with monthly cardiac monitoring. And after 3 doses of trastuzumab and pertuzumab, the patient presented again a decrease of the ejection fraction. So now she's just with hormonal therapy. So the questions to the board are: in April 2018, when she recovered the ejection fraction to 57% and was clinically with no symptoms of heart failure, would you consider dual HER2 blockade resumption? And how can we recognize the patient's major risk for cardiotoxicity due to HER2 blockade? And how would you treat this patient now? Thank you very much.
Okay, guys. So this case we chose because of Giuseppe Corigliano, because we knew he would be on the board, and then this is one of the most, the topic that he studies the most. But I think everyone here have seen this case before, and it's not a common situation, but something that may happen with the use of anti-HER2 treatments. So, Dr. Foulkakis, what do you think about the case?
Yes, well, as you said, it's not common, but when this happens, it's very tricky. So, in general, I think what you should try to do is to ask your cardiologist to try to help you. There are cases where you can, with the help of a cardiac treatment, that you can resume the treatment with a HER2 blockade, which the patient most probably will need sooner or later. Then another question I had is whether one tried to treat a patient only with trastuzumab and not dual blockade.
Okay, this is a good question.
We don't have so much data that would be better, but at least one could try.
Yeah, in the trials we have, I think, correct me if I'm wrong, but I think the data for cardiac failure is very similar with double blockage or single blockage. But this is a thing that we might consider. I think you have a point. Carmine and Gil, do you have any opinions about this?
I don't think that there will be a big difference between the single blockade or the dual blockade in terms of cardiac toxicity. In this case, it's a really hard case. I mean, the call is hard to respond or not.
In that
to be honest, I don't know what to do.
Cardiac failure, I would not expose this patient to anti-HER2 blockade. Cardiac insufficiency would kill her much faster than her disease. So now I have to weigh the risks and the benefits. And for this specific patient, I would not. I think the question of Dr. Foulkakis is valid, single blockade versus double blockade. But I think from the affinity trial, we don't see a bigger difference between them. But I don't have the data in my head here that I can recall. Gil, do you have any thoughts on that case?
No, I've actually I've been organizing the questions that are coming in from Facebook, and I have a few. If we can take them already.
Yes, let's do it.
The first one is coming from Tatiana Semiglasova from the Spot Russian group, and they have one more question on the results of the study Short Hair Trials exams abbreviated course of trastuzumab in some HER2 positive early breast cancers. Patients with low and intermediate risk had similar 5-year disease-free survival with a 9-week course of trastuzumab at 88%, as with 1 year. The risk of cardiac events was nearly 3 times lower. What is the optimal duration of adjuvant trastuzumab? 1 year, 6 months, or 9 weeks?
Okay. This is a mean question as well. We have a mean audience. It's not only us that choose the bad cases, no? The audience choose bad questions. So, Theodoros Foulkakis, you have this problem now.
Yes. So, of course, yeah, that refers to the adjuvant situation. So it's not directly connected to this situation that we have here. But in general, say that the non-inferiority of the shorter anti-HER2 treatments in adjuvant treatment is not proven. So the current standard is still 1 year, and I would await the meta-analysis of the several now trials of comparing 1 year versus shorter. But yeah, to make it short, the current standard is 1 year.
I have seen some people arguing that maybe patients with node-positive disease could be a candidate for a shorter period of the trastuzumab, which I understand because the risk is low, but we don't like these things in the new biology era. We'd like a biomarker, something that says that this disease, it is okay, and this other disease is not only size. What's your take on this? You think size matters for this, or should we wait for a biomarker?
Yeah, again, I think that the trials that we have results until now, they don't identify a group that it would be safe to give shorter HER2 treatment. But of course, yeah, it sounds logical that if we could identify a lower risk group, maybe the chance that it's enough with a shorter duration of trastuzumab is possible.
Okay, so I think your point is well taken. I think most of the people think 1 year is still the standard of care, and we encourage shorter periods, of course, because you have less toxicity, less costs, and maybe this patient could have used trastuzumab if it was cheaper for the Brazilian government at the time. So these are important questions. Joe, you have more questions, right? You're organizing lots of questions.
Yes, we do. We have a question here from Dario, and he states, for the health system implications and the value in low resource settings, for example, catastrophic health expenditures, I wonder if a general indication for no adjuvant trastuzumab in adjuvant can be stated for a PT1A or a PT1B. It's not this case, but as a general consideration on prioritization of trastuzumab. Lymph node negative disease, where the data of trastuzumab is subcentimetric disease, comes from APT Tolaney trial.
Yes, that's also very interesting point. Well, of course, yeah, we have the APT trial showing that we can at least de-escalate the chemotherapy in these cases. But from retrospective data, I think we see that these patients with HER2 positive disease, even if the anatomical stage is low, they have recurrences in a substantial percentage. So at least for the T1B cases, I would recommend chemotherapy and trastuzumab until more data comes out.
Yeah, I do agree with this. All of the adjuvant trials, they include PT1B if they had other aggressive features, but we don't have T1A, less than 5 millimeters. But we have data from the Netherlands and from the MD Anderson that some of these patients, they do benefit from trastuzumab. So I think it's very difficult to avoid trastuzumab with the data that we have today. Of course, maybe you don't have to do 1 year, or for sure we don't have to do all that chemotherapy. We have seen well with the data from the Dana-Farber Institute. But the duration for this small, maybe these are the patients, but I don't think we have data to say this now in 2018.
Yes, and to add on this, I think...
Oh, sorry.
Go ahead.
So I just wanted to mention that we now have approved biosimilars that are not as toxic financially. So one could rather try to de-escalate the chemotherapy that is more toxic for the patient, rather than trying to select patients that would not have trastuzumab.
Okay, Gio.
And on the topic of biosimilars, Franklin Fernandes Pimentel from Brazil actually asked, considering recent approvals of biosimilars of trastuzumab, are any concerns of using pertuzumab with biosimilars trastuzumab?
Good question as well. Huh? Theodoros, what do you think?
Yes, very interesting. We don't have any data, I think. Biologically speaking, I don't expect any concerns. But yeah, we don't have the data.
Actually, my take on biosimilars is we just have to get used about these drugs because the control to be similar to the originator is a lot higher than the control between batches of the originator. We know that there are little differences between drugs depending on the batch because the glycosylation chains, they change depending on the media that you put in the bacteria and temperature, but the structure is just the same in the originator and in the biosimilar. So I just think we get used to this stuff because drugs are, we have to see good eyes. This patient, maybe she could have, for us in developing countries, it's a matter of access. It's not a matter of cost. If the cost is not accessible for us, we don't have the drug. That's the problem. And I'm pretty confident that people are doing quite well, and the regulatory agencies, they're quite strict, much more than maybe for the originators. So I don't see any problem of combining or even intercambiability or interchanging these kind of drugs by the data that we have today presented. Gio, any more questions?
Let's see, Shah Seb Khan, he asked, was the biopsy from metastatic lesion not necessary regarding heterogeneity of receptor status?
Theodoros.
Sorry, there was some problem with my connection. Can you repeat that?
I'm sorry, yes.
He asked,
was the biopsy from metastatic lesion not necessary regarding heterogeneity of receptor status?
Okay. No, I think that it's important to do a biopsy because the cost. If you started treating a patient with HER2 negative metastatic disease, for example, with trastuzumab, if you don't know the HER2 status, that will be much higher than the cost and the time a biopsy would take.
I think the question of rebiopsy is that we have to have in mind that most of the times when the disease changes, it changes in the direction of losing receptors. It loses HER2 receptors, goes in the direction of triple negative. So in that case, yes, there was a receptor that could be the target, and maybe the disease could lose the target, and then you're doing drugs that would not work. So for me, it's important. If it was a triple negative, I don't see a point of doing rebiopsy. Any opinions against? We cannot hear Carmine. Maybe you close your microphone.
Hello? Okay, yes.
Now we can hear you.
Okay, so there is another question from George, and he talked about maintaining with TAM plus anti-HER2 therapy as per a sort of pertain trial. If TAM is contraindicated, AI plus Zoldex and anti-HER2 therapy.
Okay, Theodoros.
Yeah, that's definitely an option.
Yeah, I mean, this case is really, I mean, the similar to the pertain trial, where patients were randomized to receive aromatase inhibitor plus trastuzumab versus aromatase inhibitor plus the dual blockade. And actually, in this trial, the incidence of the heart problem, I mean, the NY8 class 2 and 1 and 2 were really low, actually less than 3%. And I think that the combination of blockade plus endocrine therapy in this case is a good choice, is an option for patient that maybe have chemotherapy in the metastatic setting.
Theodoros.
Yeah, I agree. I think here the issue is the problem with the hard toxicity. If you could actually give the HER2 therapy.
Sure. Okay, guys, we are running a lot ahead of the time. Lots of discussions. We are programmed for 1 hour. I have almost 1.5 hours. Do you have any last flying questions, or should we stop here and let people enjoy the rest of Saturday? Or maybe Sunday in India? Gio, do you have any questions there? Carmen?
I think that would be a good choice.
Okay, okay. Okay, guys, so thank you very much. It was a huge technical, medical, and any kind of challenge you can imagine. Thank you very much, Gio, Carmine, all the guys that collaborated. Giuseppe that could not come but just supported us. Evandro that could not join here but wasn't the first time we tried. And of course to Paolo, Georges, Santosh, Maria Alice, Atul, and Theodoros Foukakis, of course. A great discussion, amazing. Thank you very much. And the team here, thank you very much as well. We'll see the name of the guys here. They're all celebrating here behind me. So Gio, come on.
Is there any way to have a look at them, Felipe?
Yes, you can, guys.
So everybody knows who worked their...
You guys, come. You, Maria. Rafa cannot because he in the pickup.
Yeah, somebody has to work the camera.
This is Maria. Maria was here from the beginning.
Hi, Maria.
Talking with you. Beda. This is Beda as well. He solved all the technical issues, all the things you can imagine, cables and everything that you showed there. Come.
Thank you so much, everyone. And also, I would like to thank Felipe for coordinating this wonderful effort. There has been a lot of logistics that has been behind this, and Felipe has been wonderful, has been very patient, and he has been working with this amazing studio team in Brazil. And we could not have done this without him. He's been the integral part of this transmission. And we're just very happy that we have the possibility to do this with him. And we also thank each and every one of you that is out there and was here for the first live send. We really appreciate your support, and we're really looking forward to the next time we have the opportunity to do so. And we hope we have your support for that. So wait for calls for the new cases, because they'll be coming this week.
Okay, come on. Last remarks.
I just want to say thank you to everyone and have a good weekend. See you in the next discussion.
Okay, Theodoros Foukakis, thank you very much. Do you have any final words for us?
Just me? Yeah, no, I just would like to thank everyone listening. It was very interesting cases. And then you may have whatever expert panel. In these cases, sometimes there's no black or white. It was really interesting.
Okay, thank you. Can you roll the camera like this? We're doing the final roll of the camera in the studio, and then camera in the shoulder, so people see what's happening here. So this is the studio. This is everyone here. These are the guys here. This is Rafael. He's there, like look like crazy. I mean, his head is really hot now. Okay, guys. Thank you very much.
Thank you so much, guys.
I hope we do this every month with different diseases, different cases, and so stay tuned. Thank you very much, guys.
Thank you.
We'll see you. Thank you, everyone.